much. Thank you. Thank you, sir. So, next moderator is Dr. Vijay Singh. Sir, are you there? Yeah. Hello?
Yes, sorry, yeah. Now can you hear me, sir? Good afternoon, sir.
Yeah, we can hear you, sir.
Yes, good afternoon, everyone. Good afternoon, Mohit, sir. Hello?
I think Mohit, sir.
Hello,
Yeah,
Mohit, sir,
yes,
are you able to hear me, sir? Hello?
I think he is.
I am so pleased to welcome our chairpersons for this 23rd IPS PG convention, Dr. Sumit sir and Dr. Mahadev sir, and a brief introduction of the chairpersons. Dr. Sumit sir completed his graduation from College of Dental Surgery, Mahi University, and MDS in Prosthodontics from College of Dental Surgery, Davangere. He is presently working as a professor and head of department in SGT Dental College, Hospital and Research Institute, SGT University. He is a peer reviewer of Indian Journal of Prosthodontic Society. We welcome you, sir.
Thank you.
Dr. Mahadev Shastri, sir, currently working as professor in Department of Prosthodontics at Shri Sai College of Dental Surgery. Sir has done his graduation and post-graduation from Raja Muttai Dental College and Hospital. Sir has numerous publications to his credit. We are extremely pleased to have you, sir.
Thank you.
Welcome, sir. Hello?
Yeah?
Yes. So, without taking much time, sir, I would hand over the proceedings to you. And today, Mohit, sir, we welcome you also, sir.
Thank you.
I take the pleasure of introducing Dr. Mohit. Dr. Mohit Kheur has completed his graduation and post-graduation in prosthodontics from the prestigious Government Dental College and Hospital, Mumbai. He also completed his PhD in prosthodontics from D.Y. Patil University. He is a diplomat of Indian Board of Prosthodontics and was among the first 2 prosthodontists in the country to receive this honor. He is an ITI fellow and presently is the chairperson of Indian section of ITI. He is also the vice chairman of Indian Board of Prosthodontics. He has lectured and published extensively on implantology, prosthodontics, and dental material science. He is presently a professor in prosthodontics at M.A. Rangunwala Dental College, Pune, and an honorary consultant at Dr. Dinanath Mangeshkar Hospital, Pune. He has a private practice with special emphasis on restorative dentistry and implantology. He will be lecturing on provisional restorations for improving aesthetic outcomes in implantology. I hand over the mic to Dr. Mohit.
Thank you, Dr. Mahadev Shastri, sir. Okay. Can you hear me?
Sir, I think your internet connection is low.
Yes.
Please switch off your video. It may be more louder.
Is that better now?
Yes, sir.
Okay. So thank you for your kind introduction, and it's an honor and a pleasure to lecture at an IPS podium again. I heard some very nice words about me. Thank you again for that. But what I feel most proud of is what you see in red over here. Besides other things, I'm very happy that I'm a diplomat and serving presently as the Vice Chairman of the Indian Board of Prosthodontics. So I will also use this lecture as a platform to pitch in for the IBP and try and enthuse a lot of the postgraduate students to come up and become diplomates of the Indian Board of Prosthodontics. So the IBP, like I said, try and give the examinations, go through the process of certification. We are at the moment those many diplomates that you see on the screen. Dr. Sabrinathan passed exam this year only, come and join team and I'll examination and when it is, So coming back to my lecture per se, provisional restorations for improving aesthetic outcomes in implantology is what I was told to lecture upon. Implantology as a science obviously is very exciting for all of us as faculty members and more so for the young postgraduates who join prosthodontic postgraduate curriculum with many of them having a singular goal of developing a lot of proficiency in this implantology science. So there are a lot of aspects about implantology that have been discussed over the last 1 or 2 days. I was listening to some of the lectures and very nice high quality lectures. The students are going to benefit from. But what I just thought is that on a Sunday afternoon, after having heard so much, I think to make the journey easier of going through my lecture, I sat for the last half an hour or so, and I reduced a lot of the text slides, and I added more and more clinical pictures only because I think it's easier on a Sunday afternoon to sit and look at clinical pictures. Also, I strongly believe that a good picture is worth 1,000 words. So I think I'll let my presentation speak through my clinical cases that I will try and project throughout. So let's just look at that. In terms of disclosure, I am not being paid by anyone to lecture, but as they said, I am the section chairman of the international team for implantology. But of course, there is no financial interest in any product or any material or anything that you might see during the course of this lecture. In terms of learning objectives, by the end of, say, 35 to 40 minutes, what I expect we should all know is to try and understand the role of provisionals in developing aesthetic implant restorations. Implantology today is no more about, taking a CBCT, putting in an implant, and after 2 months making an impression and fixing the crown and check goes into the bank. It's not about that only. I think it's important that we refine our skills at every level in diagnostics, in treatment planning, in surgery, in prosthetics. And one out of these many different areas in which we need to refine ourselves, a very small area of these is what I thought I will choose and then try and lecture on it for about half an hour or so, So I thought that very small area that I will choose on is provisionals, the temporary phase. Sometimes what is the most neglected phase in not only implantology, but in the whole lot of prosthodontics that we do, So I thought we'll try and understand in the first part as to why should we make a provisional? What is its role? The second thing is that if we have now understood that we have to make a provisional crown, for example, in the aesthetic zone, doing a case in the aesthetic zone, maybe they can take away something about designing temporaries from my lecture. Of course, we will look at decision-making in our everyday practice, which type of abutments and what type of techniques we can use for the temporaries itself, And as I said, I'll show a whole lot of clinical case presentations. In about 35-40 minutes, I'm not going to be the guy who came and showed one case pre-op, one case post-op, 40-50 times over, because that doesn't make good learning. What I'll do is I'll take a bunch of 2 or 3 cases only and we'll dissect them from the beginning till the provisional phase and to the end so that you understand each and every technique that I'm trying to talk about. I think going down to the micro level about each case is more important than showing you 50 or 100 cases. So that's what I thought I'll do. Let's move on quickly to part 1. Should we make a provisional? So I've divided this part to make a temporary at implant placement at the time when you place the implants. Or sometimes you might want to make a temporary after the osseointegration phase, that is after 2 or 3 months down there. Each one of these separately. So let's look at a provisional at an implant placement site. What does it do? What do you expect such a provisional to do? So let's see a simple case. Like I said, I won't show you theory and research and stuff like that. It's not really palatable. like I said, on Sunday afternoon. So let's say you have a patient who's walked in like this with a fractured tooth following trauma. This is what he looks like when you look at him. Now just pay attention to what I'm showing you here at the first step. Look at the gingival zeniths that you might see on the broken tooth. The tooth number 2, one has to be extracted, and the zenith on the other one. You might just think that they're roughly the same or thereabouts, And then we go ahead with our extraction. Okay? And if you look really very carefully, the marginal gingiva has lost its elasticity because of the loss of those supracrestal fibers. And now this tissue is going to start running away from you. So this is an important factor to be borne into mind when you go and implant. So the implant is being placed in the correct 3-dimensional position, etc., etc. I don't dwell too much into that, But what I want you to understand is that now we've got to take care of this tissue over here. Because now it lost its elasticity because the fibers inside have gone. The fibers that connected it to the root piece. So we are going to we start from here, remember that. We are going to be putting on an abutment. Okay, I will be covering up this case a little later, as I said, so that we can dissect each case in detail. This is like a plastic cap that goes to this abutment in this implant system. Okay, and we have gone ahead and made a provision. That's what the provision looks like, and this is what the people going to walk out of the practice with. Of course, we will equilibrate the occlusion. We will make sure that there are no forces on this provisional in centric, definitely more importantly, centric positions of the mandible also. So this is the provisional that we will make. Okay. What do we hope that this provisional will provide? What is the role? Number one, it will support those tissues that we said here. Okay. Number two, and more importantly, there are bony interproximal peaks over here on these teeth, which are critical to the aesthetic outcome in the final run. So you would expect to make a provisional that will be flaring in that region so that it supports the bony interproximal peak. That is a very critical and an important thing to do. You will, as I said, take a nice, highly polished provisional so that you allow attachment of this marginal soft tissue. It has to attach onto something, otherwise it's going to run away and produce a recession. So it will allow attachment of the marginal soft tissue. And if you've used a good material, highly polished and nice and clean, as I'll tell you later on, it will promote maturation of the soft tissue. So when you place an implant and you're placing a provisional, you've got to take care that you do provisional right so that these three goals that you see are achieved. Okay. Gone are the days when you would place an implant, put a cover screw or a closure cap and call the patient in after 2 months. I don't think we should do that anymore. So this is what you would see as the outcome of the provisional phase. You want to see good, well-healed, mature tissue. Okay. And I told you then, if you remember previous slides, that the level of the gingiva was at this level of the tooth or slightly higher. But look at the end of the provisional phase where we have achieved a gingival margin. Now, of course, is going to be to work with the abutments and the crowns in such a way that this gingival margin comes level with this. That's a different topic for a different day. But at least we managed to convert a negative discrepancy into more or less an equal or a positive discrepancy. So now the aesthetic outcome of the case is bound to be very promising. But that is how you will do this, by achieving good provisionalization at the time of implant placement in an extraction socket. You want to see a patient like this, where the implant has been placed and you are seeing the patient now after the phase of osseointegration, which is delayed. So there's an implant inside. Okay. Implant placement in healed situation. Sorry. So you are placing an implant in a healed situation. So you've raised a flap. As we all know, in the anterior maxilla, in the first 3 or 4 months, you lose about 40 to 50% of the bone after the extraction has been done. So very frequently, when you raise a flap, you will end up with a situation that you see like this, with a whole lot of bone loss, okay, some bone destruction. The bone has run away from the root of this lateral incisor, so now there's no bone on that anymore. So unless you really treat this case properly, you are going to see an open papilla in this region because there's no bone there. Okay? So we've gone ahead and placed our implant. Okay. And now we are starting in this healed situation after the implant has been placed to start developing the provisional revision. is a standard temporary abutment, golden one that you see over here. And we are customizing it in the patient's mouth using, in this case, a flowable composite or a pro-temp-like material. It is going to be highly polished. So now we have placed it in that manner so that it will mimic the emergence profile. It has got a flare on either side, so that now once we do the bone grafting and we place the membrane and everything on the top, we are going to be trying and developing interradicular bony peaks in that region. And this particular provisional that we are placed over here is going to do the job. See how it does it, This is how, after placing the sutures after a week or 2 weeks, what the situation looks like. This is what the situation looks like when the patient has come to us after 2 months. Again, you can see a positive discrepancy with respect to the gingival margins. And more importantly, we've managed to develop some bone in the interproximal regions. Wherever you have bone, you're going to have some soft tissue there as well, So what we anticipated would be an open papilla in this region has now, because of our provisional restoration and a decent grafting procedure, we have got some interdental papilla in this region over here. Because you've grafted it, and more importantly, after grafting it, you've managed to support that bony interdental peak with the help of a provisional restoration. So there you go. Sorry. So you remember, you start from here to this point, with this point where you have everything bone loss in this region. You have made a good provisional to support everything, and you end up with a happy situation like this. So implant placement in a healed situation. Once you place the implant after the ridge has healed, you would want to put in your temporary at that time immediately after you place the implant in order to develop the bony interproximal peaks, as I said, to allow the growth and attachment of the marginal soft tissue, and you keep the temporary highly polished and very, very clean. You will promote the maturation of soft tissue. So this is how you can use the provisionals to shape up the tissue even when you place the implants in a healed ridge. Okay. So from this point on time, it is quite simple to do the prosthetics. It's all a matter of making a good impression, using the good restorative material, using a good lab. And with this patient, this is what we had as a very nice outcome that did very well at the second year follow-up in this picture was taken. So moving on. So we've done two situations where we have done the provisional immediately after the implants have been placed. Sometimes you might want to start making provisionals after the implants have osseointegrated. It means you place the implants, you wait for about 2 or 3 months, and thereafter you start the provisional phase in the aesthetic zone. Let's take a look at some situation like this. In all situations in the aesthetic zone, we are going to graft. In about 85 to 90% of our cases, we will do some sort of a grafting procedure, use a membrane on the top of that. Now, in order to develop good emergence profile, one of the things that we've learned over the last few years is that we never place an implant with a cover screw on the top in the aesthetic zone. We would always place what you see over here, which is a gingiva former. Place an implant, place a gingiva former, graft all over it, and then close the flap onto the gingiva former, even over the gingiva former, So you will have a blood clot organizing and forming nice soft tissue in the area. So you have enough bulk of soft tissue that you can shape up to produce a good aesthetic restoration. So that's just a tip that we've learned over, some years of doing implants now, So now we've closed this flap up, and this patient has come back to us after 2 or 3 months. The other side, central incisor is fractured, that's why it looks like that, This is how the patient has come to us with a flat profile in the edentulous area after 3 months of this procedure. Okay, so now we've got to start developing the emergence profile for your implant restoration. Okay, so then start with a small gingiva former, go ahead and make an impression. In this case, we are choosing to make a temporary from the lab. We will put that temporary in the mouth, okay, and then we will start sculpting the soft tissue. Okay. The sculpting or organizing or the direction of maturation of the soft tissue is something that I will cover in a little bit of detail towards the end of the lecture, But by taking this provisional off, on and off, adding and subtracting in different regions, we are able to reach a nice, healthy, scalloped, matured tissue contour. You would see like this, like a proper scalloped contour. Okay. And here on doing breaks, as I said, is quite easy. So when you're doing provisionals after osseointegration, again, the role of the provisional there is sculpting the soft tissue. My postgrads like to call it biotemporization. I don't know where they picked up that word from, but it's a very annoying word. I don't like it. We try to say molding the soft tissue or something like that. This stage, the provisional, will also help you to control the level of the marginal gingiva so that it becomes equal to the marginal gingiva or the zenith of the adjacent teeth, as I'll show you in a subsequent case. You can control the bulking up of the soft tissue interproximally by reducing the bulk of the temporary so that there is more soft tissue fill in that area. And you can promote maturation of the soft tissue as well. So again, because we did most of the things right, the patient went through the provisional phase. This is how the patient looked, more than 2 years after the restorations had been delivered. So you get really nice, stable, good aesthetic results when you do a good surgical procedure, put the patient through good professionals, but tissue matures, and then do the final restorations in that case. So it can be a quite satisfying outcome in cases like this. So I hope we've tried to gauge some aspects about why you would want to make temporaries in the aesthetic zone and at which stages, in an extraction socket or in a matured ridge, either at the time of implant placement or 2 or 3 months after the osseointegration process has happened. This is just a small part I want to discuss on why would you want to make temporaries? What are the roles? In the second part of the lecture, we just look at principles of designing this temporary. Please remember, we're talking about the aesthetic zone only. So there are 2 or 3 principles I will quickly enumerate before we go on to seeing some more clinical cases. So the first part, of course, is to make the temporary screw retained. So now there's a screw access from the back so that you can take out the temporary and then you can add and subtract on the proximal aspect, on the buccal aspect, etc., so that you allow and you direct the healing of the tissue in the correct direction. The first thing is that you have to make it screw retained. The second thing, make sure that the transmucosal contour is very critical. That is the contour of the temporary as it emerges out of the equipment under the gingiva. That contour has to be under contour, exactly the way you see like this. You keep it under contour in that region, you will allow the soft tissue to fall down and drape, and you will have good thickness of soft tissue in this region. Please ensure that this area is nice and under contoured. By manipulating this region where my cursor is, or where now I am highlighting the cursor, by manipulating this region, either by reducing it, you will allow the tissue to bulk up and the level of the marginal gingiva to come down. By increasing the bulk in this region, you will allow the tissue to go slightly apically, so that your margin of the tissue on the level of the implant is a little above the level of the adjacent teeth or that. So you can manipulate that level of the margin simply by bulking up or reducing the provisional in this region. Proximal contours on this side also must be under contoured. When you keep them under contoured, you will have more papillary fill and thicker soft tissue in that region. Ensure the temporaries are very, very highly polished, and not only highly polished, they have to be skin clean, because a clean surface is a surface on which soft tissue attachment happens far better and far more predictably than a surface that is a little dirty and unclean. So in terms of designing of temporaries, these are 4 principles that I think we should all very importantly look at. Keep it screw retained, keep them under contoured, and keep them very highly polished and skin clean. Let's look at in which situations, what type of temporaries you can make. I'll just talk about 2 or 3 techniques and then we can stop. The first situation can be chair side provisional using a stock abutment at stage 2. Let's see the case. A second one can be using a final abutment. This concept is called as one abutment, one time concept. That means after the implant is placed, you place the abutment at the same time and you never ever remove that abutment again. On that itself, you make the provisional and then subsequently convert the provisional to a final restoration. You can do a chair side provisional using a customized abutment. That's different from case number 1 where there's a stock abutment used. Okay? And the fourth one is a simple one that you can make a lab fabricated provisional. Let's quickly look at all these instances. Case number 1. Let's look at this. So a simple situation, 2 central incisors to be extracted because they were like this. So we've done the extraction. Okay. We've done the implant placements. We've done the grafting, as I said, in the aesthetic zone. We always... Okay. Now, an important thing about getting a good outcome with the provisionals is to have adequate bulk of soft. And that in the aesthetic zone by doing simple lateral roll flap, as you see, stabilize the tissue and rotate the tissue inside, and then you're able to place the gingiva forwards. We use a stock this available from all implant manufacturers. We take a putty index that has been made previously, put some pro temp into the index, put it into the mouth, and the abutments are picked up in this manner. So that's the pro temp. Now it means like all of these and follow the principles of provisional fabrication, like I said, under so that you get temporaries that look like these. This is how the provisional is in the mouth. Removed every couple of weeks, adjusted and modified the emergence profile that you want. That is how the emergence profile comes out. And then I just fast forward all the other prosthetic steps because that's not really the topic of my lecture. And really good treatment after 3 years of fall. The thing was about the take-home message was generals use a stock abutment, make a putty index of a wax up, okay, puts the flowable composite into it, attach it to the temporary, and most important, then design the transmucosal component of the temporary along the principle that I showed you, that you have good molding of the soft tissue. The one abutment, one time concept is like an abutment as the final abutment. So the same previous case, we have the implant, that's the abutment now. Okay. Once this abutment is connected, we are not going to ever remove it again. The manufacturer gives you like a small plastic cap that goes and fits very snugly on the abutment. So you don't have to like cement the temporary at all. Okay, it just snaps on, it clicks on to the final abutment. And now again, we have used a putty index and some pro temp. This is how it comes out. You've modified the temporary along the principles that we've spoken about and then fixed it inside. Okay. Now I'm not supposed to remove this abutment again, because the soft tissue will mature against that abutment, against the polymer of the resin that we are using for the provisional. And then subsequently, I will remove this provisional, make an impression like a crown bridge impression and put on the final crown. Okay. But I just wanted to be I was extra curious about the whole thing. So I took out the abutment just to look at this healing of the soft tissue. And yes, it was quite good. Okay. But this is not something that I'm supposed to do in this concept. I'm not supposed to remove this abutment, but I just wanted to see how things go, So in the one abutment, one time concept, you would place the abutment at the time of implant placement and never remove it out again. Third one is to use a customized abutment that looks like this. So this is an abutment which has got a polymer PMMA on the top of it, any which ways that comes from the manufacturer. And then you can build up in flowable composite to the shape of the temporary that you want. So say a case like this, 2 teeth to be extracted. So extract it very atraumatically. We are starting to go in with our implants, use an index to position the implant properly. And now we are using the provisional restoration. An important aspect when you do these provisionals in the aesthetic zone is to ensure that there is no force of occlusion that is transmitted onto these provisionals, because then that will be transmitted onto the implant. And we all know that implants placed in the bone must not move more than about 100 microns, otherwise they are going to fail. Okay, so the threshold of motion of implants placed in the bone is approximately 100 microns, beyond which you will have fibrous repair rather than osseous repair. So we are going to ensure that after these provisionals are placed, the patient goes home with a provisional with partial like this that does not touch these provisionals at all. Subsequently, subsequently, the patient has come back to us after 2 months, and that is how it has healed quite well, quite nice, good, matured, soft tissue. That is the recipe for a good prosthetic outcome. So immediately post-delivery, this was in the middle of the lockdown last year, so I'm not able to see the patient again. But this is what the patient looks. And from all the cell phone photographs she's been sending me over every month or so, it looks beautiful. All the papillae have filled in really very well. So the trick is to do the soft tissue management really nicely. Okay? The last one, of course, is a lab fabricated. Again, in this case, we will do the template from the laboratory. So that's how there is a case where she has lost it 3 months ago. A lot of reconstruction has happened. So we will put in the implant. We will do a whole lot of grafting on the top because that is the recipe towards getting good aesthetic results. It's not about the rest of the material or all that. It's about the good hard and soft tissue conditioning, which comes from good bone grafting procedures. So the surgical phase, in my mind, is critical. So we place the implant, like you see on the picture, never a cover screw, always a healing abutment, gingival bone grafting top, and a closure. So now this tissue has healed well. Now you've got some good, rich contour over there. So now you can start your provisional phase. So we make an impression. Our lab will design this on Exocad or some software like that and make a PMMA temporary. That is the one that usually even the best of our labs send us temporaries like this. Can you imagine that? That's how they are. But we know how the labs, how the temporaries have to be. We know how the principles of designing a temporary are. So then now we have modified this temporary so that we have kept this under contoured, we've kept the proximal area under contoured, we've highly cleaned it, and now it's in the patient part. So that's soft tissue has healed very nicely in this region. Okay, so you can also appreciate the good soft tissue, good soft tissue bulk, and everything over there that comes from the grafting procedure, and the good molding of the soft tissue subsequently with the provisional restoration. So very nice treatment outcome post insertion. I'll come to my last case. Like I said, how do you actually sculpt the tissue using a temporary? Okay, using this particular device, how are we going to sculpt this tissue? Young girl lost a tooth in an accident, okay, has a defect in the lateral incisor region. So we go through the same procedure, same old boring procedure. Place the implant, place the gingiva former, do a lot of bone grafting, achieve closure. That's how the defect heals up. Okay. Now I want you to pay attention to this carious lesion over here because it has some significance. Now we have designed the temporary. Okay. We have placed it in the patient's mouth. Okay. So initially, when I start placing the temporaries, okay, we have under contoured the temporaries on either side, on the cervical, mid-facial cervical aspect also. So now we are seeing the soft tissue creeping down over here. Okay. We have seen some bulking of the soft tissue where the cursor is over there. Okay. So now the distance between this carious lesion over here and this soft tissue here has now slightly reduced because the tissue is trying to grow inside, But the other side, lateral incisor was having higher zenith. So I added some composite onto this. So now you see there's a lesser discrepancy in the gingival margins compared to the previous picture. Okay? That's because there's more bulk of provisional restorative material over here. Okay? I added bulk proximally also. But if you see, compared to this picture, now the tissue is starting to run away. Okay? And then the patient started getting concerned about that fact, saying that this tissue is not filling. You see the embrasure is opening up a little bit because it is still the tissue and that carious lesion has gone up, So we took this out immediately, okay? Reduce the bulk in that region, reduce the bulk in this region, and in 2 weeks' time, you can see again the soft tissue has started to form. Okay, so now I didn't make the mistake of adding more bulk proximally. Okay, now the distance between the carious lesion and that interproximal tissue, if you see, has just noticed, has reduced. Then started to refine a little bit on the line angles. Okay, and this is the final provisional that we achieved. Every 2 weeks, we were mowing it, polishing it, adding and subtracting composite. Wherever we added the composite, we are reducing the height of the tissue, reducing the bulk of the tissue. Wherever we are subtracting the composite, we are allowing the tissue to fill up into that region. So this is how the patient ended up with. You might remember what was the distance between this tissue and the carious lesion when we started this off. Now it has almost touched and it is encroaching on that caries. So luckily, this caries, was acting like a guide as to where how much tissue was molding. Not that it should, but it was just in this case. So then finally we filled up that before we did the fix. And of course, customized with zirconia and an all ceramic crown is what she received. Okay, this is how she was at the time of delivery, and this is 2.5 to 3 years post delivery. A very nice treatment outcome like this. Okay, so it's interesting cases like this. I like to document my cases. I learned how to document these cases because I did up everything, a lot of case documentation as part of my Indian Board of Prosthodontics documentation process. It's a process wherein you give the examination, coming back to the IBP exam while I'm just winding up. You give the theory exam. After you've passed that, you get 2 years to build up a portfolio of about 20 cases. And that is where the real learning happens, doing cases well, taking photographs, looking at the photos, seeing that, I didn't do this right, improving your work, taking better photos, and documenting those 20 cases to a very nice level of perfection. That has been a terrific learning experience for me. So I would urge a lot of the faculty members and a lot of the young postgraduates to go ahead, step up and give the IBP exam. The next exam dates have already been announced. It's there on the website. Please go to our IPS websites. 25th July is the summer exam. On the 28th of November is the winter exam of the part 1. For those who have passed the part 1 and have finished 2 years of passing the part 1 and have built up their cases, in November this year, we will have the part 2 examination. Okay, we are going to be announcing the dates really very soon. Okay. I'll just wind up with 2 matters for the day for graduate students. Okay. First thing I like to tell you all is do less. Very funny. The guy from Pune came and said to work less. But yes, it's true. I have learned over the years that when you work less, but you work in a really nice, systematic, better manner, you end up doing more work. So don't get into a phase where you're doing one thing after the other, very mechanically. That's boring. That doesn't result in very good output. Do less work, but do concentrated work. I think that's a really important message. And for all of you all who are beginning practice, okay, trying to do your post-graduation, finishing and starting off in life, be the cheapest dentist in town, because what experience has taught me, the best and cheapest dentistry is when the right thing is done extremely well for the first time. You don't need to see the patients again and again. Okay? And it lasts a really long time. Okay? So that's an important, be the cheapest dentist in town. Funny. With this, I like to wind up. A sincere thanks to all the organizers of this fantastic online conference. I have been seeing and being involved and have had the proud privilege to be associated with the Indian Prosthodontic Society for many, many years now. And each year, this experience just keeps getting better. And I think this year, the organizers, Dr. Padiyar and his team, have raised the bar to a very high level. Incredible convention. I've read the lectures, I've interacted with everyone, and the whole planning and the hard work that has gone into it is really something that will be a benchmark for future conferences to come. Thank you so much. Okay, thank you for giving me this opportunity.
Mohit sir, it was a nice presentation. One question is there, sir. What are the challenging factors for maintaining the aesthetics for provisional restoration in implant dentistry?
The challenging factor is, of course, for maintaining the aesthetics, one of the most important factors is having good hard and soft tissue profile, which comes from your good surgery. In the aesthetic zone, as I said, 85-90% of the cases you might need to graft. So you need to do the grafting and the augmentation properly so that you have adequate volume of the hard and soft tissue. Once you have adequate volume of the hard and the soft tissue, then you can design your provisional in such a way that it mimics the adjacent tooth very nicely aesthetically, and then subsequently convert it to the final one. So I think the challenges are, number one, to have good hard soft tissue volume. Number two, to have a provisional which is nice and highly polished and very highly clean, so that you can develop the hard and soft tissues in the correct way that you want. I think these are the two greatest challenges. The third challenge is our own intrinsic challenge of putting the patient through the provisional phase. Not a lot of us do it actually, We are more conditioned to implant dalo, impression le lo, final crown bitha do, So that is another challenge actually. So it's a challenge of the mindset also to some extent, if you ask me.
Definitely.
Yeah.
Okay, thank you, sir.
Thank you.
Thank you, sir. It was a nice presentation.
Thank you.
Thank you so much, sir.
Thank you, Vijay.
Yes, it was a wonderful presentation, sir. Extremely privileged to see the photographs. Your documentation was excellent, sir. And especially the minute things which we generally tend to overlook. That was excellent, sir.
Thank you.
And thank you, chairpersons, Dr. Sumit sir and Mahadev sir. And on behalf of the organizing committee, allow me to present you with the certificates, sir, for your time and effort that you have put in, sir. Thank you so much, sir.
Thank you.
Thank you.
Thank you.
It's a great pleasure.
Okay, with this,